There, I think there's a couple things that you're talking about, and you guys know this because you deal with these clients all the time. These people they're difficult as patients, so much so that I don't specialize in pain care. Okay, they are difficult. They've got a difficult problem. I have actually coined a phrase that they've got, what was the word I was using? I lost it there. Almost like malignant pain, or their chronic pain is just like treating somebody's chronic blood pressure. If we can treat these people and give them acceptable pain relief, which is another thing that I underscore to my patients a million times. We hope the physicians maybe you guys can help us and give the patient a realistic estimate of how should they feel when they're being treated. I had shoulder surgery, and I wish I could throw the football the way I used to be able to throw it, but after the surgery, I can't. It's not 100%. I've injured myself enough to know that we don't get back to 100%, but what is a realistic goal for treatment? I find out from my patients, what's your pain level? It's 9 out of 10. I said, how about we try to reduce that pain level? And I don't say, how about I try to get rid of that pain level? How do I reduce your pain level? And let's find a level that you can live with. And interestingly enough, 3 or 4 is what most people can live with. You start getting 5, 6, or 7 out of 10, people want to be treated at that point. So, yes?
Well, I think this issue misses the issue of treatment. I mean, this is all about legislating doctors and doctors with problems. You know exactly what they're doing. They're addicting patients, very profitable for them. And we're telling them to screen patients in their own offices so that they have no doctor coming to have these people screen clear, so they just hand them a cup, tell them to the bathroom, do whatever they want. And if you look, I think Dr. Weiner is very well with this, this whole issue is addicts are addicts. So you're legislating something that has nothing to do with the problem. The problem is these are addicts. So they need to be treated. So you're spending all this money on legislation and laws and rules and judges. That's all really tied into the economy. But the true issue there is addicts are addicts, and the percentage of addicted people in the population has not risen, if at all. So that's what we need to do. We need to address the treatment issue.
We've got to front end it and not make people into more addicts. Absolutely. Right. Sure. For something else, yeah. And-
Isn't the real problem, though, that we have created a crisis, and you see that every seminar from the insurer's perspective is about opioids. The main question is about opioids. And to me, it's a self-created problem because they don't want to pay the prescription costs anymore. I see more and more of the people who are well regulated for years and years on their opioids. They're on a steady dose and they're doing well, and that everything was fine before the so-called opioid crisis came into existence. And now that it has and it's become popular, now all of the insurers are trying to cut them off of what was controlling their pain, and this is a problem. And those are the cases I'm trying.
To increase someone's pain, it's to help control those outliers, to help create the red flags. As far as the opioid crisis, it's not unique to workers' comp. Workers' comp is a small segment of it. CDC would not be spending the resources that it is if it was only workers' comp. The real problem is getting into the prescribing behavior of doctors who are overdoing it on the opioids. It's getting people to be able to function, to keep them functioning, and nobody's saying to people, I shouldn't say nobody's saying because obviously they are, but the patients who need it should be getting it.
I think too, some of that stuff, when you start looking at the crisis, when you look at who's actually getting addicted, it's 70% of the people who is receiving their prescription from one doctor to one patient. This comes from the CDC as well. 83% of the people are getting it somewhere else, okay? So we may be only speaking to a few of the patients that clients that you guys actually see as we look at this. But what happens is, I believe we kind of overdo it. We go to the other side and we tell docs this is exactly how you're going to do it, and people don't get treated perhaps the way they should be treated. I certainly believe that there is a problem with opiates, obviously, in the country. However, I think that letting, and I actually didn't get to see Ken's test, but Ken's slides, but one of the things I put up there was individualize and try to look at some new care options. Your question about genetic testing, I think, holds a lot of promise here as we're doing lots of studies on people with opiates and trying to find out, is there a way that we can find out which opiate is actually going to work better for this patient? So we're not there yet, but I think you hit the nail on the head. There we can start more appropriately aiming our treatment, and believe it or not, they're looking at those receptors in the brainstem and stuff and knowing what part of the medicine works in different areas of the brain and trying to find out, okay, this person with this genetic makeup is going to actually do better with Percocet than he is going to do with Vicodin or morphine. So I think some people are doing some of the testing now, but and you'll see some of the bigger companies out there trying to push their genetic tests. But the studies I've seen so far, and I haven't read a bunch of them, but the studies I've seen thus far are not to that point yet where we can say, do this genetic testing, prescribe this medication, because I think at that point then we're actually going to be better off, and we're going to, I don't think we get rid of the problem, but we can more adequately treat patients, which truly is what we want to do. We want to treat this client, get him productive, get him back to work or her back to work, get him back to his family and working well with his family and enjoying his family life, the whole 9 yards.
That's
Super.
great. Where
Yeah,
we're seeing
I think
more,
so.
Where we're seeing more of that genetic testing is in the major hospitals, and you're fortunate that you've got a doc who's astute on that. But think about it, when you're dealing with a cancer patient who's end stage, you're dealing with other people who have very serious illnesses outside the workers' comp setting, and unfortunately it's those docs that are leaning towards doing the testing more so than the workers' comp docs. And it's a shame, because if the workers' comp docs were, it would be benefiting the patient.
I'll get into the insurance or the docs line. You got to take the commerce out of this equation. And the problem is, in my community, upstate New York, the commerce is driving this. This is where the women, the chiropractic care, they live the massage care, they cover the veto acupuncture. What are they doing? They're pushing these people towards the opioids. Surgeons are done with them. Can't see the family practice doc anymore because the family practice doc won't step down.
Exactly.
They won't take the reimbursement. So where do they end up? They end up coming docs to see them, or to the pain docs. The pain docs, businesses are booming.
You must be in the Rochester area.
Booming, exactly. Booming. And I disagree with you. My clients admit they're addicts. They say, these places have made me an addict. I want to get off this. How do you help me do it?
But see, that's the new industry that's now growing out of this, is the get off of the drug. And Liberty has their clinic down here that they'll send somebody down to for $20,000, $30,000 for a month. I mean, do they really think it's going to cure someone? We actually have someone here, I understand, who has gone through that whole cycle. Randy? Do you want to tell us a little bit about what you've been through? Because I understand from Mark that you've been through this whole cycle of Michael. I'm sorry, this whole cycle of being addicted, etc.
No, come on up.
Come on up, please.
Rick.
I'm sorry.
No, it's okay.
Uh-huh.